So, today I've got Margaret Mary with me for this podcast. And what we're really talking, don't be nervous, Margaret Mary.
I'm not nervous.
What we're talking, we see about 100 patients a week antenatally, don't we, Margaret Mary?
Yeah.
And I thought we'd try and get some of this down on a podcast that people can listen to. Because we tend to have things that come all the time, and people ask us the same questions. So it's just to get it out there and give it in people's homes so they can listen into what we have to say and what our experience tells us. So,
definitely.
Margaret Mary, just let me know where did you come from, Margaret Mary? Where's
I basically come from the Gold Coast.
Yeah.
Came here when I was really young.
That explains a lot, but yeah.
Yeah, because I'm classy. But I went to Sydney to train, so I did my general training in Sydney.
Yeah.
Then went back to Sydney and did my midwifery at Cran's Street Women's Hospital, big
Right.
hospital, big numbers of patients,
Mhm.
and then worked as a midwife on the Gold Coast Hospital on and off for a few years, and travelled overseas for many years.
Whereabouts have you travelled? Because you keep telling me where you travelled.
Yeah, travelled more places than you.
No, I'm not too sure about that, but we've had this conversation many times. But you worked all over the
Worked
Middle
all
East.
over, yeah. Middle East, I worked in Saudi,
Yeah.
just for a number of months,
Yeah.
and as a midwife, but as a midwife not elsewhere overseas.
Yeah.
Worked as a nurse in the UK, and lots of other jobs as a waitress, cleaner. I'm good at that.
Yeah, and lots of
Nanny.
action on your travels, Margaret Mary?
Yeah, yes, I had some amusing incidences. Yes.
Maybe we'll say that for another podcast.
Another podcast. Yeah, that was a
So-
R-rated one. Yeah.
So what I was going to talk about today was really about birth and the myths of birth. We hear so much crap
Yeah.
that people come out with, and it's, everyone's experience is very different in birth,
Definitely, yeah.
and everyone has their own story to tell. And I think what I find is very important to really have your own story, and so just basically I just want to talk about what normal birth is and what happens in normal birth.
Normal birth. Everyone's perception of normal birth is different. From my experience, so culturally it's different, and I've come across
Yeah.
that
Yeah.
and just the myths behind even cultural births. When I was in Sydney, I remember there were like some Mediterranean cultures, and you knew that those girls were Mediterranean because they would say, or the mothers would say, that they had to scream because then the husbands would hear and know that how terrible it was. And in the Middle East, it was the same, but two other different cultures. They get more gold bracelets.
Right.
A couple of different cultures. So,
Yeah.
so those women's expectations was that's how that they would be in birth.
Yeah.
In Sydney, when I was down there were girls who were from Vietnam, because that was just around the Vietnam War time, soon after. So those were like refugees,
Right.
and those girls were extremely stoical, not a word. But they'd obviously gone through much hardships, and so now, because we come across a fairly reasonable, not overly broad range of patients.
Yeah.
So they're mostly Gold Coast, Australian, not
yeah.
too many different other cultures come through this private system that we're in.
Yeah.
So I think they get their idea of how they should birth from friends,
Yeah.
from magazines,
I
from
think
TV.
there's a big drive, and there seems to be a big drive from the newspapers and everything to have this natural birth, and that nature's so great, and all I know when I speak to them is expect the unexpected, because
Yeah.
labours can change quite dramatically, and when they come into labour, a lot of them, some people have this preordained idea that they want X, Y, and Z. So some of the things I've come across is, water births are fine, and I'm very happy with water births, but I think my main message from going into birth is to stay fluid and keep your options open.
Definitely.
And it's not the worst thing in the world to have a caesarean section. If it happens, it happens. The main thing is the safety of you and your child is the most important thing.
Yeah.
And if we can get a good journey along the way, that'd be great.
Yeah.
So when people go into labour, what do they expect when they come into the labour ward? They ring up, they sort of say, "Look, I think I'm contracting." What happens when they come in?
For every patient, here where I work, it's basically they come in, they're assessed.
Yeah.
But previously to that, they've given us their birth choices. They've let us know what they would like to do through their birth. And some girls are very pedantic about what they would prefer.
Yeah.
And other girls come in and are very open. And most of the girls who are open are very open to what could happen. And so I think the girls who are pedantic are the ones who are a little bit, not always a bit uptight, but it can be a bit uptight because they particularly want certain things, and sometimes those things aren't going to happen.
Yeah.
Those things aren't going to work, and I think it's those girls who aren't open, who've read too much or who've heard through girlfriends or who have expectations of themselves. So they have already decided that the baby's going to be this and the baby's going to go here and the baby's going to do this. So those girls think that the baby's got to come out and be birthed how they want it.
Yeah.
And a lot of girls can have the birth that they want. A lot of girls have like an amazing birth, amazing vaginal births.
Yeah.
They can have like a fantastic experience, and
Yeah,
even, and it can
yeah.
be, and it hurts. It hurts like anything.
Yeah.
Like, I can
There
tell
is
you.
no easy way to have a baby, is there? You know,
it hurts like anything, but
there's no painless way of having
no
a baby.
painless way unless you go straight the drug route, and
Yeah.
and not a lot of girls want to do that. A lot of women want to experience it.
Yeah.
They want to know what it's like, and
Why do you think that is? Is it because it's a natural progression of women to, it's part of their womanhood, or is it?
I think so. I think
Yeah.
so. I think, yeah, it's an amazing experience. You've menstruated. When you menstruate, for a lot of girls, there's some discomfort. Not many girls have nothing.
Yeah.
Some girls have a lot of pain.
Sure.
A lot of girls have like lots and lots of pain. The girls with endometriosis, for example, as you know.
Yeah.
So those girls go through a lot. Those girls have lots more reserves inside themselves, in their heads. And I think if their heads, they think that they've got the reserves, then their bodies have got the reserves. So if you've experienced some sort of discomfort with period pain, then that will evolve into how you can experience the labour.
Right.
Knowing, hopefully, and appreciating be a whole lot more. Mm.
So they come into labour, into the
Yeah.
labour ward. They get examined at that time.
They get examined. They get assessed first. So they assess how the contractions are from our point of view as midwives, as opposed to their point of view. Because sometimes their point of view is, like they're in strong labour, but they're the strongest contractions. Those girls have never had a baby before. Yeah. They're the strongest contractions they've ever had. Yeah. So that's a strong contraction. So we might then say, well, from our perspective and knowing what's probably ahead of you, so we can give them an honest opinion of how we feel that their labour is progressing, just externally. How the body's contracting and how the baby's progressing sort of down into the pelvis. You get an idea of their contractions, and then check on an internal examination. Okay. So all of those things give you the full picture of how that's progressing.
I think sometimes I get called and they say, "Oh, we haven't done an examination," but I think it's pretty fundamental to know if you're in labour or not. And I think you almost could expect there to be an examination if you are contracting quite well. And
I think so.
And we think you're in labour. I think that's what an examination will tell us whether you're in labour or not.
Yeah, or tell us if those contractions are doing something.
That's right.
That's right. And unless you really are doing something, abdominally wise, at the end of the pregnancy, at the beginning of the labour, then you can't expect much reward from your cervix.
Yeah.
Your cervix has to do the reward, and not many girls have painless labours. As I say, if you have a painless labour, you're going to be in the magazines. Like it's that rare.
It's a minority. It is an absolute minority.
Yeah,
I totally agree.
Yeah.
So once you're in established labour, how long would the labour on average take, Margaret?
Well, if it's a first baby, most labours, when they get established, and some girls feel like they're established for many hours, so there can be that latent phase, can be really uncomfortable, draining, exhausting.
Yeah.
We say from about 3 to 4 centimetres, about a centimetre an hour. So you're looking at, I always say, around about sort of 8 to 10 hours, and on a very average scale. Yeah. Some labours can go longer, and those labours who go longer, don't you reckon? Because the baby's
depends on position and all sorts of things, and how well
the descent, size of the head. Yeah. The head's got like a mould and. Yeah.
And you've obviously had a vaginal birth before, and I've often heard you describe the ring. But what's it actually feel like when you push that baby up?
You really want to know?
Yeah. Look, I think it's important that
It feels like you're having a pineapple with the skin on.
Yeah.
Like the burn, and it's when you pull your mouth like that when you're a kid. Yeah. That burn, it's like that. Right. Like maybe tenfold. Right. But with this watermelon squashing everything down there. Okay, you got 3 orifices. The biggest one wins. So the head's this big. The bowel gets squashed. The bladder gets squashed.
I think as a male obstetrician, I just wonder why you do it. But anyway, but look, it is the most rewarding thing.
It's rewarding. It's amazing. And if you can have a vaginal birth that goes well with, that's straightforward, then it's great. It's great. But also, some girls don't always, play the game in the straightforward fashion. Don't you reckon this is digressing.
Absolutely. I think
but if we all eat so well nowadays, and the babies are getting bigger, the husbands are robust, so you get these big guys and little girls, and You get these
Well,
babies and
I see it all the time. I think when you first meet somebody who's tall, has
strapping
chap, and you think, oh,
you get jealous.
Yeah, well, I do, but you go, oh, he's great, he's fantastic,
Yeah.
he's got muscles and all the other assets that he
Big
may
bones,
he may want to have, but you don't realise you've got to push him out.
It's right.
And
Yeah.
I think that's always the worry, and we do get that mismatch quite a lot. Where you get some very tiny ladies with
That's
quite
right.
big guys, and
I say,
it's normal for people to try and balance out their perceived flaws. I think and
Yes.
my perceived flaws was to get someone slim and tall, and fortunately I did.
So did
and,
I.
yeah. So just to balance out the children,
Yeah.
so they don't have the same
Yeah.
problems that we had when we were growing up of being called names.
Yeah.
Not many names, to be honest. I was quite hard and strong, so
Yeah, so
no
they
one,
were game,
no one
yeah.
gave me any crap. Honest. Anyway, but once you've had that birth and everything, I think the thing a lot of people get disappointed, and I think you only get disappointed when you've got expectations, and I think when you've got expectations of what you're going to do in labour, and you don't fulfil those, or you have such a set and rigid plan that I don't want epidural, I don't want this, I don't want that, and then you have to have it. The disappointment afterwards is quite hard, We often send people to our psychologist, Beck, just to sort of debrief, because
the expectation.
But that's right, and my two bits of advice is to stay fluid, leave your doors open, but also when you get pain, is to be as relaxed as you can.
Yeah, exactly.
And when you're relaxed, you lay better. When you have pain, you tighten up. So when you what you need to do in labour is relax and let that cervix open. And there are different ways of achieving that. And we're going to come on to calm birthing and hypnobirthing in a minute, and water births as well, because I think that helps relax you. And some people need the epidural to relax. And sometimes they're chugging along in labour and they're stuck at 4 centimetres. I put the epidural in. Oh, I don't, but the anaesthetist does. And then 2 or 3 hours later, they're fully dilated and ready to go. So I think it's all about relaxation.
Relaxing this end, I say to girls, like, basically chop yourself in half. So the top half is breathing, and definitely any of those other ways, calm birth, hypnobirthing, yoga for pregnancy, any meditation, any sort of, other ways of calming yourself, relaxing, so that you can get into a bit of a zone. So it's basically, switching off, getting your head into another headspace, believing that your body can do it, so that this end just breathes. So it's slow breaths, keep your diaphragm moving. Once that's moving, then the bottom half has to do what it's got to do. And soft legs a little bit apart and leaning forward, and it's really hard to tighten your butt. And if you tighten your butt, you tighten your pelvis. If your legs are wide, leaning forward and rocking your pelvis, which is the other end of your body, then that's really easy early on in the labour.
I find that again, when people are pushing, they push with their perineums. And I think that's counterproductive. You should be using your diaphragm and your stomach, muscles more. Your rectus abdominis, that gives me that six-pack that I'm hiding so well here.
It's very warm.
But it is a bit warm. But and to keep that perineum relaxed, because all you're doing when you're pushing and you're tightening up there is you're pushing against yourself. And I think the thing to do is try and keep those legs relaxed, so keep those adductor muscles of your legs from closing in tight.
That's right. And squishing the head.
And sometimes putting them in that lithotomy position with the legs up in the air, is the way to go, because
it helps.
It relaxes things, and I use
But also, going back from that, the squatting, so you can squat, and like your husband can be behind and they could just lean over his arms like that, and so they could squat, so legs are wide, left lateral, or on the side, leg up in the air. Same sort of thing. You don't have to worry about your legs when they're up in this in the little lithotomy position, which is up like this. But the same thing, getting them wide and letting that be relaxed. And you push like you're having a poo.
Okay.
Because if you're using your diaphragm, push the axis of the baby's body, which is straight to the bowel. And so when obviously if you're constipated, because of course never you've been constipated, but if you're pushing down onto your bowel, the baby's head's just going to go where it has to go. It's got to pivot under that pubic bone.
That's right. It's
so you're pushing with this.
The famous curve that
the
was
S-bend,
designed by a doctor who's male.
Obviously.
Because
who would have to come under there?
Yeah, and once you come under there, it almost comes on its own,
That's right.
And
but you still got to keep pushing that way.
Yeah.
Because that will.
And just.
The neck bends. The neck will come around and curve when it's ready to.
It extends upwards. That's right. So, and when it comes out, it's just to be relaxed as it comes out, because the feeling that most people get, I think, is that they want to push when it's maximum burn. Yeah. And the thing to do is try and blow, because that head's coming out slowly, just and avoids that real tearing. Yeah. So whether it's panting, blowing, whatever, one of those things will help just bring that head out nice and
just
slow.
Nice and slowly. Yeah. And I think the reason you want to be so expulsive is because the bowel's so squished.
Yeah.
You know, the bowel is so squished from that head pushing on there.
Yeah.
You feel as though,
It's
you know,
full.
like you really need to do the biggest poo ever. So you're
Yeah.
pushing that
Yeah.
sort of sensation, and you can feel your body can do it. You just want to get it over with.
Right.
Your body just you just want to do this. God Almighty, like, let's just get this done. And we've heard girls say, just get it out of me. You know, like,
absolutely.
you'll do anything.
Absolutely.
You just want that over. So it is.
I've been asked for a Caesar many times at that point, you know, and
It's really hard to push it back up.
Yeah, it is really hard to push it
Take
back
it
up.
out,
Yeah,
yeah.
no, that's right.
Yeah.
But you know, people always say that it's more painful having a caesarean section, you know, and I don't think it is. I think the pain's in a different place, especially first time. I think second time, if you've had a vaginal birth before,
Yeah.
I think the second time you reap the rewards of having that difficult birth
That's-
or the
yes.
pain with the first one, and the recovery from
And
a
the
second
length
birth.
too,
That's
yeah,
right. The length
yeah.
is a lot shorter. So I think when people are talking about their great deliveries of, you know,
The second baby.
it's usually the second baby, you know, because things are, you know, the icebreaker's been through there before, and the other little boats are following behind, and they're absolutely fine. So I always find, you know, that the descriptions they get are the second and third births.
Second, yeah.
But people.
The first one was awful, but the second one was great. It was like, because
But
hello.
what I find equally amazing is how amnesic it all is, because people suddenly forget once the baby's out.
Yeah. Oh, absolutely.
The turnaround, you know, they look like death warmed up for while they're pushing, and then as soon as the baby's out, it's just
It's
like
just this euphoria.
Oh,
it's insane.
It's phenomenal. It's the hormonal effects of that, and all the relief and the combination of all that.
But even at any birth,
Yeah.
even like a really difficult birth, you know, using instruments, perhaps, you know, that it's just knowing that the baby's out, and I think hearing that cry too.
Yeah.
There's that whole, like, thank God, because you know
Yeah.
you can hear the baby's alive, you know, when you hear the heartbeat. But just actually see it and see it's
Breathing.
got all the bits, even though you know it's got all the hands and beat and whatever.
Because everyone panics that the baby doesn't cry is a bad thing. It's not always,
no,
you know.
it's not.
And all babies sometimes take 2-3 minutes to really.
And sometimes they come out and their eyes just like, holy dooly,
Yeah.
what just happened?
That's right, and some are screaming on the perineum, you know, with the head just out, you know, start crying and you go, look, it's too early for that, just hold a minute.
Hang on,
You know, but they are all very different, and I think there's that brief moment of panic that goes around the parents. And what I
Sometimes
normally
midwives.
and what I normally do is just wink at the parents, because I know the baby's fine, you know, it's
Yeah.
just a matter of just sparking up after the first 2-3
Yeah.
minutes as it changes from that, you know,
That sort of
from
fetal circulation to the
more baby circulation, more adult circulation.
Yeah.
And you know, when we deliver the baby, a lot of people asking me about cord clamping and how soon should we do it. And you know, there are advantages and disadvantages both ways. You know, and I've always in my career let the cord pulsate for a while the breathing comes into action. I think that's always been good practice. But there's a big drive now to leave the cord for as long as possible.
Yeah.
There are advantages of that, of course. You know, the blood count's a lot higher of the baby, but they are more likely to require the ultraviolet lights because they're jaundiced.
They're jaundiced.
So it's trying to find that right balance. And I think a minute or two is more than sufficient.
But how much you reckon, if it's going from the, you know, like the cord's pulsating, it's going in. So if it's pulsating, it's coming out again.
Yeah.
So there's only, can't be a huge amount. There's going to be a bit more.
That's right.
But what goes in's got to come out until it
That's right.
stops. So
That's right.
I think if you do clamp it a little bit earlier, I don't think it's going to be ridiculous
No,
amount
it's not.
of
It's not.
Yeah.
It's not ridiculous at all. But
But
you know, I think
I think it's nice because then the baby's the one who's leading the way as to
Exactly
I'm
right.
ready to be here now, so I don't need that anymore.
That's right. That's right. Yeah. So, just moving on to Caesars. You know, and, you know, we have this fear. Lots of people have fear of Caesars, or you know, and they say to me, I don't really want to have a Caesar. You know.
Yeah.
And you know, just go through the process of when you come in. Say you came in for a planned Caesar. I know that the emergency
someone
Caesars
said,
are very different. You know, where things are a bit more rushed, and we take you downstairs, and there's not much time to sort of plan. But what actually happens in a Caesar from a patient perspective?
They're admitted, and that's just a normal hospital process. Wherever you are, there's a process of observation to make sure the stability, get you ready into theatre gear, and basically then down into the pre-op area. If you haven't already previously been reviewed by the anaesthetist, they'll come and see you before the procedure starts, and then they take you around to the anaesthetic bay. Drip goes in. Obviously, you need fluids prior to the spinal. So, and then sit on the side of the bed, curling over for the spinal. The spinal needle's really, really fine needle, so it's not like an epidural needle where you need to leave the plastic tube in. So the spinal needle's in, and the medication goes in, and it's out very quickly.
And that's the difference between a spinal and epidural. But the
quicker.
epidural is a catheter, and spinals are just a one-shot anaesthetic that goes in the back, which lasts for about a couple of hours. Whereas the epidural is that catheter which you can maintain it, but it's not quite as strong as a spinal. And so people always say, oh, when we get the epidural and the Caesar, we don't use epidurals, and it's spinals predominantly.
And it works quicker.
Yeah.
So they get a warm flush down their legs.
Yeah.
But as you said, it only lasts for a few hours. So
Yeah.
I think, how long do you reckon? 15, 20 minutes most before, 15 minutes before you get a really good full effect?
It varies on what you use in the spinal,
Yeah.
and that depends on your anaesthetist. But you can do a Caesar in 5 minutes after a spinal, or sometimes it takes a little bit longer, depending on how quickly that rides up through the to numb the whole area, I guess. Right.
And so then once it's in,
Yeah.
once the spinal's in, catheter into the bladder, because
Yeah.
you need the
Drain
bladder,
bladder,
the bladder drained, and then the anaesthetist will keep testing to make sure it's where they like it to be effective before the patient's prepped. Once the patient's prepped and draped and
we crack on and do
have a baby.
Yeah,
It's
and
5 minutes later.
It's under 5 minutes the baby's out, and then about 15-20 minutes, depending on who's doing it, to get the baby to get it all closed up and everything. A lot of people ask me about skin to skin and things like that. And we do try. I mean, I know you try to get the baby back onto the mother, and as a surgeon doing the operation, it makes no difference to me whether the baby's on mother or not. It doesn't interfere with my field at all, and I'm pretty pro them getting skin to skin early. And one of the common complaints I get is that I didn't get any skin to skin last time, so we really try and get that
particularly in theatre. I think it's planning it to make sure it's not too cold, because sometimes the aircon's right above them, just blowing straight down. I think the paediatricians have to be able to have a say, because they're the ones then ultimately responsible for the baby. So if they're happy with the baby, I think within a minute or so, baby comes from you to me to the little trolley, dried, weighed, and while the baby's getting dried and weighed, if necessary, I can prepare the mum. So prepare the area down here and bring the baby over to the mum. It's usually within a minute or so. So I think the mothers want the babies there. Some mothers aren't feeling good. We hear them. Sometimes they're not well.
You sometimes get some vomiting because the blood pressure drops and things. So sometimes they feel quite tired because they do I think they put opiates into the spinal as well. So I know they do get a bit tired, but baby then gets transferred to mum anyway,
wrapped up, and dad can be supporting.
But when we take them out of theatre, they're sent to recovery for about 20 minutes,
and skin to skin as soon as we can.
Do you feed in?
So if you put the baby close enough to the breast and the baby's well, you try and let them do it themselves. You have the baby nearby, but you don't sort of push it on. So you let the baby, look at the mother. I think they need to get that eye contact. Hear the parents' voices. Like, I try and not talk too much. I talk a lot, I know, but try and not talk too much in recovery, because I think for the baby they sort of really just stare and take in the parents' faces. And I think that they can take in their voices. They're getting the skin to skin, so they're getting the flora from the parents. Get the dads to touch the baby. So just, I guess, imprinting the parents' faces and voices on their little sort of person, and then you move it down towards the breast. And some babies just start mouthing around, and then bobbing their heads looking for it. So sometimes they need a bit of a hand to sort of get it on, because the mother's laying flat. You need to shake that breast up a little bit for the baby sometimes. But just depends on the mother's anatomy, really.
And when they get back to the ward, obviously, I don't obviously see what happens straight away when you're back to the ward. You do observations and things.
Regular observations. You want that mother to be quite stable physically, because she has had an operation. So that's one aspect of looking after her. So I liken these jobs as midwifery jobs and obstetric jobs, because obstetric jobs are ones that we want from a midwife's point of view, but to look after her having had a baby. Whether she's had a vaginal birth or a caesarean, you need to look after those things. But you also want to do all the lovely midwifery things that we're taught from early on. It's just that skin to skin, that helping the mother to sort of basically know who a baby is, let the baby know who the mother is, help with the feeding. The skin to skin contact is pretty much imperative for that baby to have that contact. But then, of course, those babies who don't have that, we try and get the mothers into the nursery if the baby has to go to the nursery.
And the recovery is the first day. The first day they're always just laying flat.
Drug them.
Absolutely. Loads of drugs. Second day they tend to get a bit more mobile. It's a bit uncomfortable.
Uncomfortable, but just keep the medications up. Not so many that they're spaced out, but enough that there's definitely going to be a little element of discomfort. You can't have absolutely painless. But if you expect some discomfort, and I say to girls, the first pain you'll feel before the spinal completely wears off is like the afterbirth pains, the uterus contracting. So that's as it seems to wear off in this kind of fashion. So they feel it a bit here as they're getting movement in their legs. So uterus contracting, and then it moves down to the wound. And I liken it to as like electric shocks and a bit of sort of muscle pulling. So if you've got the uterus contracting, zinging here, and it's like pretty
intense.
Hooly dooly, yeah.
Yeah, okay.
Pretty sore.
And so,
medications.
Medication. Second day, they're up and about, have a shower.
Yeah, slowly.
Yeah,
slowly. Catheter comes out, the drip comes out slowly, sitting on the side of the bed. And I'd say this would be anywhere that girls are birthing.
Okay.
It's usually about that, if you birth one morning, about 24 hours later, the drip usually stays in for about 24 hours. So, yeah, catheter, get them out, up and about. Some girls want to get up that evening.
Yeah.
And, it's definitely a little bit of a hand, but...
Yeah, and usually when I see them on the third day, they're usually pretty mobile by then,
Yeah,
and
feel reasonably comfortable.
Most
some
are.
medications still,
Yeah.
but just slowly backing off on the harder ones.
Yeah.
And then by the fourth day, regular hard, like opiates are decreased.
Yeah.
And but yeah, by the fourth day.
The fourth day is always a special
You love
day.
that day, don't you?
I always go in early on the fourth day,
Yeah.
because of the
little
baby,
bit sad.
the little bit baby blues when
Yeah.
what they say is the tears start rolling, the milk
Yeah.
starts flowing, and
Yeah.
it's always I come in early and get it over and done with.
Yeah, how you going? Right, okay, see ya.
Yeah, it's a very short visit the fourth day, and then the fifth day they're usually back to normal, and by the sixth day they're ready to go home.
Ready to go home, yeah.
Very much
yeah.
so,
And some girls who've had babies before, know what to expect and might want to go home a little bit earlier. Those girls, I think, should stay as long as they can, because once they get home, the toddler or whatever, husband, are keen for them to be back to normal.
And people come and visit, and there's no way you can say no, and whereas in your hospital, you've got the midwives to protect you, and so say, no, she's tired, leave her alone.
They need signs on the door, mother's sleeping.
No, that's right.
Don't knock, yeah.
That's right.
Yeah.
But, I mean, that's the John Flynn thing, but I think in other hospitals, like the public system, you probably only get 2 or 3 days in hospital, which I think is a little bit short, but,
Look, that's the ideal, is a bit short, but ideally those girls have got some pain relief for when they're at home, so that they can be mobile, so that they can still look after the baby, because the main thing is they want to get up and about to look after the baby.
Yeah.
They want to be able to feed.
People, there's a lot of confusion about when you can drive and when you can't drive.
Yeah.
And there's no actual set date, and some people say 6 weeks. I don't think that's true. I think you can drive day 7, and in my experience,
maybe they don't want to.
Yeah, but a lot of the patients can, and they do, and they will drive at day 7, and they're absolutely fine. But you just have to okay it with your insurance company. I think that's
the main
thing.
thing.
And they usually, if I sign you off, which I do, then you're good to drive on day 7. I think.
Yeah, but give them a bit longer.
Yeah, I think 2 weeks is more.
Maybe 4 weeks.
I think 4 weeks. You reckon?
Yeah, well, they're going to go up their shops and do the shopping otherwise.
A lot of my ladies are a bit more dynamic, and they want to get up and about and do things.
No, they don't. They want to stay home, get looked after.
They want to go out for coffees and go surfing and things, by the sounds of things. But and leave the baby on the beach or in the car.
On the baby, sunbathing.
Yeah. That's right. But
I think a few weeks. Yeah.
Yeah.
But I think they've got to take into consideration. Maybe if it's just them popping up the shop, just to have a little bit of a break.
Yeah.
Otherwise, you've got to put the baby in the thing. You've got to get the toddler up in the car seat.
I know.
So it's all that lifting, and we don't want the lifting. We want that wound to heal.
All I know is that my wife Donna was. She was driving to Tesco's in England.
Yeah, to get away from you,
on
probably.
day 3, yeah. Well, I shouted at her, I didn't know where she was, and the car had gone, so I rang her, and she said, I'm at Tesco's shopping.
And I'm not coming home for 3 hours.
That was 3 days after Caesar, so I was just like, okay, fine. I said, where's the baby? She goes, I've left it at home with you. So I said,
can you go and find it?
Yeah, I had to go find it somewhere. The poor thing, anyway. Neglected child of mine.
They still love it.
But so just quickly I know we're going to cover lots of things in a separate podcast, but just talking about VBACs and things like that.
And the hypno we talked about.
I think we should talk about instrumentals and VBACs and hypno and calm birthing. And those are these 3 things we should really cover here.
Yeah.
VBACs, basically, I think it doesn't matter why you had a Caesar the first time. You've got a 60 to 70% chance to have a baby vaginally second time round.
Birth after
and
caesarean.
there are risks, and that risk is about 1 in 200 of having a uterine rupture, which is a very significant thing. It's a major problem, because babies in that situation don't do very well at all, and mothers don't either. So, but as long as and this is why we monitor with CTGs, because the first signs of uterine rupture are slight abnormalities in the trace, and it's not pain. And a lot of people think it's severe pain that's the thing. It's not. That's not a very good marker at all. So, but VBACs can be successful, and as long as they're in a safe environment, I'm very happy to do that.
And a little bit of a gap between babies.
Look, I don't know if there needs to be a gap, and the average muscle takes 6 weeks to heal.
Yeah.
Say it's a uterus, I'd say 3 months, and the number of patients we've had have got pregnant straight away. There's a randy lot out there,
They're on the Gold Coast.
That's right. They're pregnant and they're having babies within a year, So, but you can, but I think I don't know if the evidence suggests that there is a slightly higher risk of rupture, and it depends which paper you look at, but I don't think there is. I think the uterus is probably fully healed by 3 months, and most people say not to have kids for a year, but I say we've had them all.
We've had them within a year.
Within a year,
yeah,
you know,
like
and
the same day, just
they
about.
virtually to have get pregnant in John Flynn.
Yeah. No, they're not that bad on the Gold Coast.
Well, I don't know. Anyway, I do know have some stories.
Yeah.
But yeah, anyway, but that's basically VBAC. But just tell me what's the difference between calm birth and home and hypnobirthing.
I don't think there's a real lot of difference, and the hypno girls will probably ring me and tell me really soon. There's I think the basic crux of both of these kinds of birthing, and I think it's the different ways that the women are taught.
Yeah.
It's the relaxation. It's the getting your mindset into a positive frame of mind, and I think just imagining how your body's working. And they use different analogies, you know, like opening up like a flower or any of those kind of things.
Because it does, doesn't it?
Oh yeah, I feel so flowerful. Yeah.
What sort of flower
is it? Little flower.
Is it gladioli?
Or a great big stick one. No. What's a great big flower? A big sunflower.
No, I do know the tapes quite well. I think I almost go into a trance myself after hearing them, you know.
Yeah,
because
you've got to stay awake because you've got to help them birth.
But when I go into hypnobirths, what I do find is a very quiet environment. And
it is,
when I walk in there, I usually just wave at the patient, you know, because I don't want to take them out of that, you know, situation.
That zone.
And they're in that zone, and they know I'm there.
Yeah.
But they're just stay in that zone all the time.
But you know, like hypnobirthing and calm birthing, they're fantastic. Those girls, even if they have to go on and have some other assistance with their birth, those skills they'll never lose. Girls who have had a lot of experience with meditation, yoga, relaxation, they can still get into really good zones, and still they might not have in their heads, you know, my cervix is opening like a flower, but they can still know how their bodies are working and work with their bodies. So I think if you've never done anything like meditation, yoga, just breathing exercises, then definitely hypnobirthing, calm birthing, any sort of assistance in those kind of ways, I think it is fantastic. Yeah.
I think there's different strokes for different folks, you know, and I think everyone has different ways of coping with those things, and it appeals to some people, and it doesn't appeal to everybody. And you know, just because it works for one person doesn't mean it's going to work for you. So you've got to find what's right for you and what relaxes you. I think.
Some girls don't want to do any of that stuff.
And marijuana is not an option.
No, it's not allowed even on the Gold Coast.
That's right.
But I think if you're not really into any of those kind of things, some girls are much more contained and can't let go.
Yeah.
And those girls are much more, I'm just doing it, this is how I'm doing it, it's black and white. And, you know, and it works for those girls because they're structured in their own, you know, sort of firm sort of a way.
Yeah.
But not they're the girls, but some of those girls, you need to help them to relax, to keep that bottom end of them relaxed, as you said before. So you don't need an epidural, perhaps, if they're so tight.
I think the high working achievers, you know, the ones who work hard, you know, so you know, those who are very OCD, I don't want to tarnish all of you, and you'll be cursing me for saying this, but people like teachers, lawyers, they're very, very much OCD in what they do, and they almost approach birth in that way, you know, that it's a problem, and
it's a project.
That's right.
It's a project,
you know, it's not, you know, and I don't know what we find that I find that a lot, you know, that because they do like to achieve, and I think they almost grade themselves on their
teachers.
That's right, the teachers
10 out of 10.
You can spot them a mile away, can't you? But anyway, not
all of them, but occasionally they bring notes.
To be honest with you, about 50% of my patients are teachers, so
apologies to all the teachers out there.
That's right. If you're listening, I do apologise. But no,
they'll be marking you too.
They will be marking me. They'll be marking this podcast. What are you talking about? You've got a B- so far. I reckon I've got an A. But
A for arsehole.
Thanks. Yeah. But just quickly, just to touch on instrumental, I get a lot of people saying I don't want forceps, you know, and you know, the forceps have been around for over 200 years, you know, and they haven't changed much in design, to be honest.
I don't know that I have.
But I think in the right hands and the person who knows what they're doing with them, they're a very safe instrument. And look, there comes a time when you have to have an instrumental that if the baby's in distress at full dilatation, or you know, there's you've been pushing for an awful long time, because it does cause damage to that perineum if the head's sat there for long periods of time.
Sometimes the position's a bit skew.
That's right. Yeah. So the two things the two weapons of choice are really a vacuum, where you put a suction device onto the head, and what it does, it causes a little swelling on the head, and that's how it works. And you get what's called a chignon for those French speakers out there. But it's a chignon which basically will go after 24-48 hours. You know, and you pull with that. You can't pull very hard with a vacuum, so you do need a lot of push. It's all about redirection, and it's about changing the force of that push and getting under that pubic bone and then coming up to the surface, and then the forceps is a bit more different. You know, it's obviously looks a lot more brutal. They're massive, and
I think because they do look a bit scary. The handles,
they do look scary, you know, and they look clunky, and you think, God, you're going to put that around my baby.
And they do clunk, don't they?
They do clunk, you know. I do it on purpose sometimes to stimulate people to push, and they do push. But when you put the forceps on, you basically you apply the forceps around the face, so you are going to get marking around the face. And that's
but it cradles the baby. The bony parts, doesn't it?
That's right. That's right.
So it's mainly this bit.
Yeah.
And
if you've got a big chubby baby, you're going to get more depression on the face. So, but that goes again within 24, 48 hours, you know. And so for a vacuum, you need a beanie. For the baby, and for a forceps,
whiskers.
You need some L'Oreal makeup. Just pop it on.
So we'll just be very kind to them. But as you said, there's a place for them.
Yeah.
There's a time and a place that.
There is, and 7% of births are probably done by forceps or vacuum.
Okay.
So 7%, and you know they are, and they're first timers usually. Second time you tend not to use it. Second time because the uterus is so much more powerful, and because the eyes,
and because it's already been stretched.
Yeah, that's right. The tunnel's a little bit bigger, so but
it's
just practice. That's right. So just allow that baby to come through, but you know people do worry about it. But the forceps is actually safer for the baby.
Yeah. And I think it has to be also the practitioner.
It does, absolutely.
Like it has to be what you feel at that point in time.
That's right.
Yeah.
And you only want to use one instrument. You don't want to use two.
Yeah.
So if the vacuum you know is going to come off, and I've done this a couple of times where I put it on because they didn't want a forceps, and in my heart of hearts I wanted to do forceps, and the suction's just rubbish, and I need to put the forceps on. Once I put the forceps on, the baby's out.
Baby's comes out, yeah.
But you know the forceps is safe for the baby, worse for the mother.
Yes.
And the vacuum's better for the mother. Worse the baby, and that's the way it's always been. So but and
I think like perineum, the women concerned about tearing or needing a little cut, and sometimes that.
To be honest with you, Mark, this is probably the most informative I've ever heard you, and
you've got no idea what else I know.
Well, you know, I think I've really exhausted you, but we're going to try another podcast.
I'll do my homework.
We're going to talk about some of the controversies that we think are around in the next podcast, including vaginal seeding and
what's the other one?
The tablet.
Placental encapsulation.
Placental encapsulation, really a very common topic now that people are coming in and asking us about it, and we'll talk about it with the next podcast. But for the time being, thanks a lot, Margaret Mary.
Pleasure.
And you can't have a pay rise, no.
I was going to ask for that.